So we have this 45-year-old patient who comes in for a refractive surgery. So there are various methods by which one could treat this patient. Now, presbyopia, as we know, is inevitable in middle age, and to treat presbyopia along with other refractive errors, you could either use a keratorefractive surgeries, or you could use something called as prelex, that is presbyopic lens exchange. The problem with keratorefractive surgeries, where you would have to go in all cases for a monovision, is that it's got quite a few limitations. As opposed to that, prelex is a long-term stable solution with binocular vision. So what are the limitations of corneal refractive surgeries? Basically, it does not address the root cause of presbyopia. Refractive surgeries done on the cornea can cause higher order aberrations and therefore can affect corneal contrast sensitivities, especially in these middle-aged patients as they turn older in age. And there's a higher risk of dry eye syndrome in these particular patients. Again, there may be a regression which occurs over a period of time which will require retreatment. Again, there's no long-term correction of presbyopia. As age increases, the presbyopia will tend to increase. And when this patient has to go in for a cataract surgery, the difficulty would arise in the IOL power calculation. On the other hand, in cases of keratorefractive surgery, in most of the cases, we would do a modified Q value treatment, also called as the FCAT treatment. So what happens is the non-dominant eye, there is, you increase the Q value to make the cornea hyperprolate, and basically the depth of focus is increased. Whereas in these cases, though there is an increase in the depth of focus, there is always a problem of reading at a very close distance of 33 centimeters. So again, because of this monovision, there is a reduction in the stereopsis. Not all cases may undergo a good neuroadaptation, and therefore the results may not be always successful, and it basically compromises the vision between the two eyes. Presbyopic lens exchange, on the other hand, treats the cause of presbyopia along with the refractive error at the root cause, that is the cause of the lens which has now become dysfunctional. So you can have your normal clear lens replaced with either a multifocal or an EDOF lens, and it gives you a spectacle independence for all distances, far, near, and intermediate, and it is a permanent solution. Again, there is no risk of developing cataract. So it's beneficial for all patients who are more than 45 years of age, who are looking for freedom from glasses, patients who have started developing cataracts but who are still not eligible yet for a cataract surgery from the visual point of view, people with active lifestyle who want to engage in sport activities, and patients who want something permanent to correct their presbyopia. And basically this can treat all types of refractive error, whether it's a myopic, a hyperopic, or pure presbyopia. So literature has also proves by various studies that the superiority of prelex over corneal refractive surgery. So basically, like I said, it is stable and permanent, no regression. It gives you a binocular vision, better contrast, no higher order aberrations created, prevents cataracts in the future because your crystalline lens is out, no issues like dry eyes unlike a LASIK or a PRK, and it is a customizable procedure because you can have your own choice of a IOL which you choose. Again, like I said, all forms of refractive errors can be treated. So you can either use a multifocal IOLs or the EDOF IOLs in these cases, depending upon what the patient's needs are. A short video just to demonstrate. It's very important here to understand that this is a patient with a clear lens. So one needs to perform this procedure after being thorough with his cataract surgeries in elderly patients. A good rexis, minimum 5.5 millimeters with a good cover of the IOL is important in these cases, because we cannot have a decentered lens, especially in an elective procedure like this. Again, a good multi-quadrant hydrodissection and a hydrodelineation helps because these cataracts are soft, so you don't need to use any phaco power. A good soft cell technique to prevent any endothelial cell loss. Basically, it's an elective technique. Being an elective technique, you can't induce any other complications or any other problems. So again, like you see, we're using only an aspiration technique here. We're not going in, hardly any phaco power is being used. The nucleus is already freed. And This particular case, we are able to do it without a second instrument. So no side port has been created in this case. And just with playing with the vacuum and the flow rate, the entire nucleus can be easily aspirated. Again, a good cortical cleanup with polishing of the posterior capsule as well as the rim of the anterior capsule is very important to prevent PCOS. Remember, these are young patients. Lens epithelial cell hypertrophies can occur and they can develop an early opacification of the posterior capsule or the phimosis of the capsular rhexis margin. So again, a proper cleanup is very important, and this can be followed by the lens of the choice. So in conclusion, it is important to understand that presbyopia is a problem with the lens. It's a dysfunctional lens, and it's always better to treat a particular condition at the level at which the dysfunction occurs. And treating presbyopia on the corneal plane is like punishing the cornea for mistakes of the lens. I know Rupal is going to not agree with me in this, but again, like I said, it is horses for the courses. So there are different cases where one would need to treat the corneal cornea also with a corneal refractive procedure. So I'll hand over the mic to Rupal to counter this.